Good evening to everyone. Uh, Khalil, can you hear me, please?
Yes, I can hear you, and hopefully you can see me too.
Yes, I can see, and thank you very much for agreeing to this session. Everybody's looking forward because they are very much interested in barium. Just one second, let me mute. So people are looking forward to this session, and thank you very much. So just a quick introduction. Dr. Khalil Al-Gendi is a senior GI fellow at St. Mark's Hospital in London. St. Mark's Hospital is a world famous hospital, particularly in GI. You know, procedures and things like that, particularly rectal and fistulas, and you can go on and on. Historically, this is a GI center par excellence. So we are lucky for Dr. Khalil to be doing this session with us. Thank you very much. And candidate one, are you with us?
Yes.
Okay, so we have got four candidates today, and without wasting further time, I'll hand you over to Khalil. Thank you very much.
Thank you very much for your kind introduction. As Dr. Hamling, my name is Khalil Gendi. I'm a senior fellow, Master of Training St. Mark's. Previously, also, I've been 4 years in Imperial College, and hopefully you can hear me clearly. Please let me know if any issues. I've done colorectal surgery also before that. I'm originally from Egypt, came to UK about 11 years ago. My voice is very low. Okay, let's see if we can fix that. Is that still the issue? Sorry. Low voice, okay. I'm gonna try and see the audio setting, but is the highest I can get. So I can get closer, or I can put a different mic. Is that any better for everyone? Please do. Okay, thank you very much. So I'm just grateful for this chance of presenting teaching. Always teaching is been my passion in radiology and before in surgery. I think it's a message, and I'd like also to acknowledge my previous professors and teachers back in Egypt, where they give us free lectures at 6 o'clock in the morning. We're all queued to attend it. So just the message from this always to teach your colleagues, teach your students, teach your seniors also. So teaching is a way forward in medicine in general. So without further ado, I'm just going to start. There will be a few interesting cases. What I want to say also, this is not about you knowing the diagnosis, it's about dealing with uncertainty. You can't know all the cases in the exam in the 2B, but you have to have a systematic approach. There'll always be cases where you'll never see before, and that's true for real life. So how to approach them, how you have a systematic approach, that's the key thing. Not only in your thinking, but also how handling emotion and during the stress during the exam. This is two important elements when you do the 2B exam. So you pass the 2A, so it's not about the knowledge now, it's about how you apply and how you present yourself. There's two elements of what we're going to do today. You'll see a lot of interesting cases. Hopefully, we're starting with fluoroscopy and then rabbit shooting X-ray, abdominal X-ray, depending on the time available. But let's kick off, and please keep this in the messages. Hopefully, somebody from the group also help me with the messages of any questions or any cases. But let's start with candidate one, and hopefully find a way to share the screen. Yes. Okay. Just I think somebody has to unshare so I can share my screen. Can you see something now? Hopefully. I'm using collective mind, and somehow I chose this arrow. Hopefully not for all the cases, but for this case at least. So candidate one is
Yes.
hello. So this is a patient who presented with some difficulty in swallowing, so we did a barium swallow. So you can request control, or I can run it through to you. So this is the AB view. It's up to you. What you feel comfortable with, and that's the lateral view. Probably I will just put it side by side. See how it counts. Access. Okay, stop sharing for 2 seconds. See later styles. That should be here. And technical issues files for this. Okay, so you got the AB view and the patient having difficulty swallowing, and then you got the other view, which is the lateral view.
Excuse
okay,
me,
these are
Khalil.
Sorry? Yes.
At times, what happens is that your sound is there is a bit of a problem at times where it is slightly low, and then
Okay.
it becomes okay. So there is an issue. If you can, maybe you can, if you can be closer to the mic or whatever.
I will try. The other option is to look through on mobile also, and it will be that the audio. But I'll try the headphone for 2 seconds and see
Yeah.
if that working. Can you hear me now?
Yes,
Is that better?
I think it's better.
yes.
Excellent. Thank you.
Yeah, thank you.
Share again. Sorry about that. Let's start again. Hopefully you can see something now. So we got the AB view and lateral view of barium swallow for the patient. Can you see what you can request control if you like, or you can tell me what you see in the abnormalities.
Yeah, I think I'll tell you what I see.
Okay.
So these are AP and lateral projections of the barium swallow, and I can you play the AP one?
Yeah.
And there is an extrinsic impression in the mid esophagus.
Okay.
It's a smooth impression.
At what level the external compression?
Sorry?
You say there's external compression. At what level?
Yeah, it's mid thoracic esophagus.
That here, yeah.
Yeah, yeah.
Okay. What do you think that caused by?
Would be a benign lesion like an leiomyoma.
On that area. Okay. What that shadow? Do you see that shadow? What do you think that
Yeah,
is?
that's aortic.
Okay. Is that what you mean? Yeah.
Yeah.
Is it? Okay. That's just normal impression by the
Okay.
water. What else you can see?
So I can see the esophagus. The barium is normally outlining the
Okay.
upper esophagus, the
Mhm.
the pharynx and the upper part of esophagus. I can see. So there is a outpouching
Okay.
at the level of
Good.
C6 on the
Excellent.
lateral view.
Yep.
So this could be a Zenker's diverticulum.
Okay. And what made you think that's a Zinker diverticulum? Was any differential?
Because it's at the level of C6 and mostly at this level we get this diverticulum.
Okay. Well, there's 2 types of diverticulum mainly. There's more types of that. There's something called, so I'm going to do some teaching now. So thank you for that. There's a Zinker diverticulum. That's true because you can see the the cricopharyngeus muscle here indentation.
Yeah.
So if it's above the indentation, called Zinker diverticulum, yes. And that's a small Zinker diverticulum. You can see it's retaining the contrast. If it's below, you will call it Killian-Jimson diverticulum. But that's a different. So that's the 2 differential groups for that. The rest of the barium is normal. So I'm going to show you another companion case. So in 20 seconds. And tell me, probably that's a bit more obvious. Can you see the new case or not? It means I need to show and reshare. You can't.
Sorry, I couldn't get what you're saying.
So I'm showing now a new case. Is that
Okay.
apparent to you? Can you see new case or not?
Yes, I can.
Okay, so I'm going to just make that bigger and tell me what we see.
Yeah, okay. Again, I'm presented with a lateral projection of the barium, and there's a big diverticulum.
Yeah, okay.
Yeah, again, it's at the level of 2, 3, 4, 5, 6.
It's more about the indentation of the pharyngeus. But okay, there's a large diverticulum. What else also you can see on that barrier?
So there's irregularity of the hypopharynx, and
Yeah, okay. You mean that area?
yes, and there's some aspiration into the.
Exactly. So there is a problem in the mechanism of swallowing. It's not irregularity, it's just the patient cannot empty the larynx properly, and then that resulted in aspiration. So this is a Zinger diverticulum, and that what happens sometimes we have a problem with the swallowing mechanism, or you can get the diverticulum a lot distended, and that diverticulum you can see is just regurgitation of the fluid, and we can cause aspiration. So this is Zinger diverticulum with aspiration, just to show you that kind of thing. And there's another companion case to show you that range of diverticuli in that region. We move to another case, so 2 seconds. Let's close that one. And what you can see here is another patient who had some spinal fixation. So I'm going to run that through to you and tell me if you can see anything abnormal in that one. It's a bit difficult to study, but this is a more of a true diverticulum. It's a complication from the spinal fixation, but you can see that's outbouching again laterally at a different level. It's a bit higher level, but that's at the level of the spinal fixation. That's one of the other. So the learning point here is just you need to look again. There is a more inspiration, as you can see. So whenever I show you upper one, just think about the reticulum outbouching, a problem with the swallowing mechanism. But I'm going to show you also more cases. I think we can move to candidate 2. And I'm going to show you another case. Right, so the candidate 2, this is a patient who's complaining, 18 years old, 20 years old, who's complaining of difficulty in swallowing.
Okay,
Right,
so should I start?
Yeah, please do.
I'm provided with upper GI study, and I could show concentric narrowing at the level of upper esophagus.
Yeah.
I could see 2 rings at the level of upper esophagus, and with mild upstream holdup of contrast. However, there is a normal passage of contrast inferiorly as well. So, considering the location, I'm thinking of cervical webs, and I would like
Yes.
to correlate for any iron deficiency anemia to exclude Plummer-Vinson syndrome.
Thank you very much. That patient actually presented with anemia, exactly, and that's multiple cervical webs. And as you mentioned, it's Plummer-Vinson syndrome. So well done. That's well spotted. Management and etc. So you have to investigate and look for, as you mentioned, anemia in other cases. But that's just a classic case of Plummer-Vinson syndrome. Thank you very much. Stay with me. I'm going to show you another case. I know that very well with that one. And the diagnosis is multiple cervical webs with that patient. The part of the history is the anemia, and then that will be Plummer-Vinson syndrome. There's still a problem with hearing. Okay. Still, is it bad? Still, I can look in from a different machine. Okay. So different. 2 seconds. Sorry. I'm gonna stop sharing. That's a problem. And looked into differently. I'm looking to a different account. If somebody can just allow that to unmute me, please. That would be great. Any better? There. Okay. Just again. Look through the mobile, but I don't know. Can you hear me more clearly now? The only other option is just to get very close. So I'm looking at a different account of somebody.
Yes, sir, I can hear you.
Okay, thank you very much. Appreciate that. Okay. Let's crack on then. Right, so this is in upper. Hopefully that now working well. So this is another study, barium study, and we got candidate 2. Can you tell me what do you see in this case? I'm going to run a few of them. I'm going to put 2 slides together. That's the first one. This is another run here. Please go ahead. Hello. Do we have candidate 2? Sorry. Can you see the screen? Okay, I'm not sharing again. Oh, that's my mistake. Let's start again. Okay, can you see now the screen? You can see a screen. And who is with me now from the candidates?
Yes, sir, I can see it.
Okay, so what do you think?
I'm provided with the barium study,
Yeah.
and I could appreciate that there is herniation of stomach above the diaphragm into the chest cavity. So can you please move it? With the suggestion of a stricture or narrowing at the gastroesophageal junction. So I'm thinking of a hiatal hernia with a stricture at the gastroesophageal junction.
Well, it's the GOJ. It's difficult to say sometimes that when you see that structure is there's not causing any holdup, isn't it? So that's what type of hernia is this?
So it is sliding.
Sliding hernia, yes. And that means that GOJ is above the hiatus, basically. That's,
Yes, sir.
so we will call it type 1.
Okay.
So just to show you another case in that one, and tell me if you see any difference for this case, and then we move to 3 perhaps. So I'm going to show you run this study.
So I'm provided with upper GI contrast study, and I could see a smooth diverticulum just above the lower esophagus, just above the gastroesophageal junction, likely representing an epiphrenic diverticulum.
Okay, what else could it be? Maybe show some pictures and then that will help you. So I would say just wait till you see what is happening. I mean,
Sorry, sir, I'm unable to hear you clearly.
sorry?
I'm unable to hear you.
Okay, so just looking at you said that could be a different, yeah, it's got diverticulum. What other differential are you thinking when I'm running this study?
I'm thinking that the gastric outline is not clearly visualized. I think that the stomach is protruding above the diaphragm, but I'm thinking that this is no the rolling type of paraesophageal hernia, maybe.
Yes. And what
Because
helps you to differentiate between both?
because the gastroesophageal junction is seen below the diaphragm, and I see outpouching, protruding just close to it, above the so the junction is just below. So I'm thinking of rolling type of hernia.
Rolling bump hernia, yes. So that's flouroscopy hernia, as you mentioned, or type 2.
Yes.
Excellent. I'm going to show you one more case, and then
Okay, sir.
you tell me what you see. So this is another swallow. And hopefully it will work. It's just some error. Oh, I might need to restart it and share again. Still loading. And hopefully you can hear me clearly now.
Yes, sir. I can hear you now.
Good. Okay. So it's just still loading. Definitely. So this is another oral study for patients who actually had the symptoms of reflux. I'm going to just run quite a few images here. Right. If I just stop in this image, what do you think that could be? Probably not uploaded right, and not loading right. So anyway, this is a case of type 3 hernia, which is basically both the hiatus hernia and also rolling hernia in the same time. But it just doesn't project as it should. So we just move on from that one. And if I have candidate 3 with me, please. If anyone has a question, please stop me, and we'll take time with illustrating the cases.
Can you explain this case once more?
This one of the images is not loading right, but basically it's a recurrent hernia where you can see that the GOJ is up high here, but also this part of the stomach is herniating. So they call it type 3. So it's just a companion case. You've got type 1, which is sliding hernia, and then you've got type 2, which is paroesophageal, which we see in one case, and this is the case 3, which is basically type 3, which is both having sliding hernia and paroesophageal part of it also, which due to recurrence or weakness in the diaphragm. It doesn't project well, the image is not loading, so I'm going to just leave it there and move to another case if that's okay. Here we load another case and hopefully it loads all right. Now, next candidate, this patient who presented with the 50 years old, presented with difficulty in swallowing. I'm going to run that and tell me what you see slowly. Anything? Hello, candidate 3.
Yeah, Assalamu alaikum, sir. Yes, sir.
So,
Sir, can you run it again? Sir, I have been presented with the series of barium swallow in which I can see a stricture at the just below the impression of the aortic knuckle, and it appears to be there is mucosal irregularity and subtle shouldering effect of the stricture in this picture. So, considering the age of the patient, 70 years with difficulty in swallowing, my first most probable diagnosis will be a CA, a carcinoma, because of the mucosal irregularity and the shouldering effect in the age.
And so what do you want to do next?
So I would first inform this to the referring physician, and I would like to do a CT chest with contrast in order to see if there is any mass in the specific area.
Okay. And what are you going to do next also? Anything else?
Sir, I would recommend if it proves to, if there is a mass, then I would like to see its relations and further request for the endoscopic biopsy.
Okay. So the main thing here is to do endoscopy, yes, and the biopsy, and that is confirmed as cancer. So in UK, you have to have certain things specific in your mind when you're faced with a case where you suspect the cancer. So the first, you have to confirm that, and the endoscopy will be the first step to see what that irregularity and highlight it and red flag it. You get an endoscopy within 2 weeks, and then that refers and biopsy, and then you do a CT staging scan, so the whole body
Yes.
scan,
Okay.
go up to
Okay,
abdomen and pelvis, and then
First will be endoscopic biopsy and then CT. Okay, sir.
refer to MDT for discussion.
Okay.
That's
Yes,
very
sir.
important. So that's we need confirmation, staging, and then MDT. Okay, that's important.
Okay, sir.
But well
Okay,
done.
sir. Thank you.
That's great. Spotting abnormality, which is esophageal cancer. Okay. I'm going to show you a companion case, if you stay with me, before we go to the next candidate. And I'm going to just. Right. So this patient is a different patient who had also difficulties swallowing, has been diagnosed with esophageal cancer. And then we have been asked to do a barium swallow for him before the planning for stenting. And I'm going to load this image and just tell me if you can see any problems with that image.
Yes, sir. In this barium study, I can again see a linear, irregular structure that is seen at the almost just above or at the level of the aortic knuckle, and there is a holdup of contrast proximally. Apart from that, I can see aspiration as well. That's most probably because of the holdup of contrast, and so and there is no passage of contrast distally into the stomach. So it is like a stricture that is a stricture which is with associated aspiration and obstruction that is not letting the contrast go further beyond its level.
What other differential you got?
Sir, it could be it can be an outpouching, holdup of contrast in a pouch. I would like to see a lateral view that will be.
Well, that's the images we have here, but that's the
Yes,
holdup,
sir.
and we know that's esophageal cancer. But what
Yes, sir.
about the appearance in the trachea? So you see some contrast in the trachea, yeah?
Yes, sir.
What could be other cause for that?
Therefore, cause for the aspiration?
Well, it's not aspiration, basically, because the upper trachea is not.
Tracheoesophageal fistula. It could be the fistulous communication because of this cancer between this esophagus and the fistula. Yes, sir.
So yes, exactly. You can see that's the communication between the esophagus
Yes, sir.
and the
Yeah.
trachea. So that's a malignant tracheoesophageal fistula. Don't forget about that. Cancer can erode into the trachea because of the nearby structure. And what could we do to this patient?
Sir, again, first of all, we will. I don't think whether endoscopy will be possible in this case or no, but
Well,
we will
find
do.
it difficult to pass it through, but we managed to get samples, and we know that's esophageal cancer. What could be
So, sir, biopsy and then CT staging and then referral to the MDT.
Yes. But is anything therapeutic we can do for the patient? Not therapeutic, but
Yes, stenting, sir. We might be able to do the stenting and also this obscure. What do you
I
say?
don't have the images with me, but this patient has had esophageal.
Identify the fistula and sir, try to treat it with.
Exactly. So what they done, they put on the stent, and that covered the site of the fistula too.
Yeah, covering the fistula site. Yes.
It's a palliative treatment anyway for this case, which is advanced esophageal cancer. Excellent. Thank you very much. I hope that case, and hopefully my voice is clear. But that's a case of malignant tracheoesophageal fistula. So just another.
So your voice is clear, but it's just you're speaking too humbly, like.
Okay. Thank you. Fine, I will give a shout now. So yes, that's a case of malignant tracheoesophageal fistula. Just think about what could be other causes of that when you see. So you observe the contrast in the esophagus, observe it in a different pathway that shouldn't be there, and you thought about the aspiration. That's very good differential. But another cause of that is malignant erosion. Okay, excellent. Thank you very much. Then we have a candidate for them. Okay, candidate 4, can you hear me?
Yes, I can hear you, sir.
Thank you very much. So this is a patient who had also some difficulty in swallowing. So around 50 years old. I'm going to run the study. You just tell me if you see anything abnormal, and that's the lower part of the esophagus.
I have been presented with upper GI contrast study. Here I can see that there is evidence of dilatation of the esophagus is noted,
Yeah.
and there is filling defect is also present within the level of esophagus.
Okay.
And there is the contrast has passed within the stomach.
Okay.
There is some mucosal irregularity also evident at this level. There is no extraluminal contrast is noted.
Okay.
So this can be some filling defect at the level, and there is a delayed passage of contrast within the lower esophagus. So there may be some obstruction at this level.
So what's your differential? What's your be so dilated esophagus, some irregularities in the esophagus, that's true. But what is causing the dilatation of the esophagus?
There is a smooth narrowing, and also there is evidence of bird beak appearance. So this may be a evidence of some ecclesiocardia.
Echalasia, yes. So do you know what types of echalasia?
Yeah, there are two types, like the primary ecclesiocardia and the secondary. Secondary ecclesia is due to some obstructing mass lesion, and primary is due to some like muscles are not working well. The nerve plexus is not working properly.
Yes. So basically, there is a defect in the nervous plexus that doesn't relax the junction, relax the lower esophageal sphincter. Okay. And what do you think that sign? Do you know what sign this sign called?
Sorry.
You need to do it. So that appearance.
That's bird beak appearance.
Bird beak appearance. And do you think there's any? What do you suggest is it for the next step?
The next step is a upper GI endoscopy, and if there is some obstructing mass, then biopsy can be done. Apart from that, contrast and CT scan of the chest, and referral to the gastrointestinal MDT for further management.
Okay, if the endoscopy was normal and we think this is a primary echalasia, do you know what would be the management of these cases?
Then there can be a balloon dilatation, or some botulinum toxin can be given for this management.
Excellent, thank you. But not botulinum toxin. I don't know if that will work, but usually it's you try dilatation. If not, you can do operation, which is cardiomyotomy, classically happen. Okay, excellent. Stay with me. I'm going to show you another case. That's mostly the discussion, as you can see. Just understanding is nothing too magic about barium. That we'll get into more other cases where we upgrade the game a little bit. So this is a patient so this is the X-ray. Let's start with here and tell me, what do you see in this patient?
I have been provided with upper GI contrast study. Here I can see that there is also significant dilatation of the esophagus. And the contrast has passed within the lower esophageal junction and also within the stomach, but there is a delayed passage of contrast.
So do you see contrast in the stomach? Yes or no?
Like it is going through the gastroesophageal junction, but not has reached.
So okay, do you see anything? What is that?
There is a band, gastric band, I think.
Okay.
That causing some obstruction at the upper esophagus level, gastric band surgery.
Okay, so what do we call this? So this is a tied gastric band, yeah? So there's a hold up, the patient cannot pass the contrast into the stomach, yes? But do you think it's any problem with the gastric band itself?
I think it is like it is making an acute angle, so I think it is normally placed, it is not migrated.
Yes, good. Do you know what the name of that angle is? You have a name for it?
No, sir, sorry.
It's called phi angle anyway, so don't worry. So it's, as you said, that's just indicator whether the band is in the right place or not. And it's acute angle. So the band in place, and you can look at the line, and there's no discontinuity or anything. And then the patient scores in hold up. This is one of the commonest complications of gastric banding, that the patient have difficulty swallowing, and we just put too much in the gastric band. So what you do, you just go and put a needle in the reservoir and try to get some of the fluid that the band out, and then you can redo the
So can you repeat it again? Oh, sorry.
So the management of this case, you aspirate fluid from the band, from the reservoir. That's the reason why you put a needle in it. That's subcutaneously. And then you put a needle in it, aspirate it. That will make the band less tight. And then you document that. That could be done in the clinic or done under fluoroscopy. But this is the case of tight constrict band. You might see that there's a lot of bariatric surgery and other things. So you might come across that for sure. Looking for one of the complications of the gastric band. The position in slippage, but also being tight. Okay.
Okay.
I missed the chat. If somebody from the coordinating help me with any question, please let me know. It will be difficult for me to follow that chat also. Okay. Good. And now back to candidate 1. I'm going to show you one case from the upper GI. And so, candidate 1, can you hear me?
Yeah, yes, I can hear, but not very clear.
Yes, I'm trying to look in through the mobile, and I think that would be easier, but somehow it's not letting me speak through the mobile. If somebody can let me in from the team, would be good. So otherwise, I'll just have to shout at the screen. I can try with the headphones again, but some people say it's not working either. So let's see. Let's try. Try the headphone again.
Yeah, it's okay.
This is baby. 4 years old with problem with vomiting. I'm going to just pass it through all these sequences quickly. But tell me if you see any problem anytime, yeah?
So I'm presented with the upper GI study. This is a barium meal, and I can see the contrast opacifying stomach, and it is seen opacifying the duodenum, but the contrast is not passing distally.
Okay,
so this is probably...
Fast forward. Can you hear me, yeah?
Yeah.
Okay, what do you think is happening here? I'm going to look at that picture. I mean, ideally, I need to just give it a second. That's better. So I'm going to load some images.
Okay, now I can see that the contrast is passing into jejunum, but the jejunum is on the right side of the...
Yeah, okay.
So this is a case of malrotation.
You think this jejunum is on the right side? What are you saying? Okay, if I showed you this image, I'll just make it bigger. That's the DJ.
Okay, the DJ is on the left side.
Yeah. That's the earlier phase. We can look at that next. I think that's the best images. Then go there, and then that's yeah. Can control somehow the control. Oh yeah, okay, that's better. I'm sure that one is better, easier. Sorry about that. Okay. What do you think is happening here for this patient?
So
it's right thinking. If it's not crossing the right side, what would be your diagnosis?
Malrotation.
Yeah, malrotation. That's true. So that's a good point, a good observation. But what are you observing here that is still you can't see is a problem with the duodenum? Yeah.
Yeah.
I don't know if you heard about this case, but so this is not gut malrotation, but you can see long redundant duodenum. It's something called duodenum inversum. I don't know if you came across it before or not. It's something that's a rare thing, but it's part of the differential for gut malrotation. Some of these patients might need surgery, some not. It depends on the symptoms. But most important is that you can see that's the fourth part of the duodenum is crossing into the right side in this image. And what is happening here, the duodenum is folding itself, is very redundant, going upside and down, and then go in back and go in front and behind the stomach rather than front of it. So that's what they call duodenum inversum.
Sorry, what is it called?
Duodenum inversum.
Okay.
So it's just a case of one of the differential that when you see abnormality in the duodenum, it's a rare congenital malformation. But if I try to show you a picture from one of the websites, probably there's an article on RSNA quite nice about this. But just look it up. It's one of these rare cases. But it's just a question that in this case, and I know it's you might not come across it before. I don't know that will show up. But basically, as you said, is excluding malrotation, is abnormality within the duodenum. I'm not going to ask too much about this, but this is another case of duodenum inversum. It's one of the rare cases. Let's read about it. In this case, usually treated conservatively and depending on the symptoms. Good. Okay. If you stay with me, I'm going to show you another study. Now we're moving from the upper GI, and that's the most commonest diagnoses or abnormalities in the upper GI. So we're going to move a little bit on the head and neck side of the things. And I'm going to show you a study. Candidate 1 with me, yes?
Yeah.
Okay, so I'm going to run it quite, and tell me what this study called.
Yeah, this is a xylogram.
Excellent. What xylogram of?
This is for the submandibular.
Sure.
So this is a there's a beading of the.
Is it which gland first before we go? It's not the submandibular.
Sorry, it's a parotid. Sorry, it's a parotid gland.
Excellent. Okay.
Yeah,
So
yeah.
what do you see here in this picture? So this
So
is
there is
parotid xylogram. Exactly.
Yeah. So this is there's alternative beading and structure of the main duct.
Okay.
The smaller ducts are normally opacified.
Beading is a good description. What else do you see?
I can see a filling defect.
Okay.
Yeah, in the proximal part.
And that keeps with what the filling defect means.
Be a stone, a calculus.
Yeah, excellent. So, yes.
Yeah. So this is a chronic cell adenitis secondary to the calculus.
Okay. If I tell you this condition is bilateral, what other differential you can think of?
Bilateral could be mumps or.
Okay, good. What else?
Some chronic infection.
Yes.
Like TB or.
Not TB exactly. That doesn't come bilateral, but autoimmune disorder. Do you think it's going to think of something?
Yeah, Sjogren's syndrome.
Thank you very much. That was a case of Sjogren's syndrome. So you beaded appearance of the parotid gland bilaterally, and then you got a stone impacted here. So well done. You have you seen a parotid xylogram before?
Yeah, I have seen a parotid xylogram, but not this case of Sjogren's.
Yes.
Like this.
But it was not difficult to guess, yeah, isn't it? So you got the appearance, you described it right. Getting the diagnosis right or wrong is not a problem. You got the right description, you got the right examination. But the next steps, I would like to look at the other side, check the patient history, and then if it's bilateral case, then we need to think about other systematic causes, as you mentioned, find viral infection or bacterial infection if it's unilateral viral infection, and then also autoimmune disorder. Okay, thank you very much. I'm going to move to candidate number 2. Hopefully the base now is okay with you guys and the voice is clear. I don't know what else I can do really. Right. Candidate 2. What do you think that is? What is that examination? What abnormality you can see? So got this. Hello. Do we have candidate two? We can move to somebody else. Yeah, it's been unmuted. Okay.
Khalil,
Sir, please unmute candidate 2. She's not able to unmute herself.
okay, just hold on, please. So, Khalil, you have finished with candidate 1?
Yes, for this case.
1 second, let me candidate 2.
I'm trying to swap different cases, but I'm happy to maybe give candidate 1 or 2 longer time. If that makes things easier.
So you are going from 1 to 2 and then 1 to 2 once again. You're doing it like that?
No, I'm going 4 and then 1 again. I think that's the order. So candidate 2 was in
Right.
order after candidate 1.
My question was that your plan is to give 30 minutes to the candidate 1 and
Okay.
then
No, my plan is to just get different cases in different parts of the body rather than a specific time. But I can do that too. It's not a problem. Okay.
whatever, because another formula is that you can show a case, both candidates can be with you, 1 and 2.
Yeah.
And
Okay.
you can show one case to candidate 1, second case to 2, come back to 1 for the third case and fourth case. You can swap like that also. So,
Okay, we can do that. That's absolutely fine.
so now you want candidate 2
True.
with you? Candidate 2, are you with us?
Yes, sir.
Okay.
Okay.
Lil, over to you.
Thank you very much.
Yeah, sir, I'm provided with the cellogram images of the submandibular gland, and I could appreciate a narrowing at the proximal end, close to the submandibular gland. In addition to
Okay.
that, there is a small um, uh, small rest of the rest of the submandibular gland duct is normally visualized. I could only appreciate narrowing at the side of a junction of gland in the duct. This one.
So meaning that bit.
Yes.
So what about this? You think? And if I zoomed in here,
I could. I think that the duct is a bit dilated, and there is
yes,
a filling defect
exactly.
at its opening site, close to the base of the tooth. I think it's the opening site of the duct.
True. That's in the floor of the mouth, basically. So we got filling. This is submandibular cellogram. You got a filling defect in the distal part, and upstream dilatation of the duct.
Yes.
That's how we should present it. So that's the, what can you do to this patient? What usually the next step?
So we can send the patient for an oral exam and the retrieval of the stone.
Yes, and sometimes you can do also intraoral ultrasound to see where is the stone, and sometimes even you can do it. And some of head and neck radiologists do that too. Okay, I would like you to stay with me. I'm going to show you a companion case of this.
Okay, sir.
This is another. It's submandibular cellogram. Yeah, about the CT now. I'm going to show that later to you, and I'm going to run the sequence. And then tell me what can we see. So, seeing abnormalities now, we're taking an exposure, which I think is the best thing to do. And tell me what do you see?
Sir, I could appreciate that the submandibular, again, this is a cellogram of the
Yes.
submandibular gland, and I could appreciate that there is mild prominence of the ducts within the gland.
Hmm.
In addition to that,
What else you can see?
I could not appreciate any obvious filling defect. I could just see a small bump close to the angle of mandible.
Okay. What
That
do you
could,
think of that? What was that?
maybe it's some, I'm not sure. I think it's a,
Okay, that's the accessory duct, basically.
okay.
So that's the main gland, that's accessory duct, and there's a stone in the accessory duct. And what we've done to the patient is we've done a CT2, that's in the mouth, and we feel and you can
Sir, I
see
could
it.
appreciate a stone on the right side
Yeah,
in the
so
trajectory of the,
it's you can see that. Oh, yeah, you can see.
yeah, there's a stone here on the right side.
Yes, on the floor of the mouth. So that's basically a case of so just put it all together. Stone and accessory duct related to the gallbladder plate. It's a rare thing,
Okay.
but
Okay,
you can see that's the calcification projected here, and then you can see the
okay.
of the CT, which is the diagnosis of the duct. Sometimes we can do CT for the patient to see that, very limited CT. You can, as you mentioned, refer to the ENT to examination and deal with the stone for stone extraction, and depending on the symptoms. Excellent. Thank you very much. That was well done. I'm going to move to candidate 1 back again. If they're available.
So candidate 1 has some internet problems, so she asked me to continue on candidate 3.
Yeah, please. Okay, please do. I'm going to look now a little bit towards the lower GI tract, just to change scene. And this is a patient. This is an old study. Okay, I'm going to run some pictures, and you can tell me what you see. I'm going to stop in one of these pictures.
I've been presented with the barium anima studies, spot images, in which I can clearly see a stricture in the sigmoid colon. To characterize it, we can call it an apple core structure with shouldering and irregular mucosa. And my top diagnosis in this case of elderly male will be a carcinoma, CA. So I would refer this for endoscopic biopsy, and then a CT scan, abdomen, pelvis, and chest for the staging, and then refer to the MDT.
Okay, excellent. And what other differential for sigmoid stricture?
Sir, less likely could be inflammatory, but like ulcerative colitis. And apart from that, it can be because of infectious, but comes down in the line.
Okay, so diverticular disease is the top after the cancer. And
yes, sir. Diverticular. Okay, yes, sir.
Yeah, that's the main thing. And then you can get, say,
disease.
And extraluminal causes. That's another thing. Should be.
Yes.
External compression. So you need a CT, staging scan, and endoscopy, as you mentioned. Excellent. What other things do you want to know from this imaging that helps the surgeons in deciding an important point when we talk
Sir,
about
I would like to know any fistulous communication between this stricture and any other organ, like and with the small bowel or with the bladder. And apart from that, like in sir, from the fluoroscopy, what else we can know?
What other information helped the surgeon also about deciding the urgency?
Sir, the holdup of contrast or related to anything like any obstruction related to it, any formation of megacolon or perforation, any signs of perforation, contrast leak, to see signs of acute peritonitis or anything.
Okay, excellent. Yeah, it's just obstruction. So this is stricture. Is upstream obstruction or not? Because that means either we can do, depends on the staging, no one does stenting anymore, or we can do diversion for the patient, or we can move, if the staging is early cancer, then we can do directly to surgery. Yeah, so upstream obstruction is very, very important. Thank you very much. Stay with me. I'm going to show you
Yes, sir.
another case. So I'm going to load up the images on the level. It's a bit slow. I'm just going to get 2 by 2 for now, and then tell me what you see. Let's go in this picture. Let's pick the next 2. What do you think? What is the type of the study and what are the findings?
So it is actually a double contrast studies in
Yeah,
which there is
excellent.
outlining by the air as well as by the positive and negative contrast both.
Yeah.
What I can see are the multiple filling defects which are seen along the walls of the colon,
Yeah.
most probably representing polyps.
Excellent.
And my first and foremost diagnosis will be any polyposis syndrome.
Excellent.
And
What type,
further,
what polyposis
a
syndrome do you?
familial polyposis syndrome, sir.
Okay.
FAP.
Yeah.
Or Pers-Jaeger. Maybe I'm not pronouncing it well, but Pers-Jaeger syndrome. These 2 are the topmost.
Okay.
Further, I would like to advise for the endoscopy and
Excellent.
and also the clinical history to know the details and
If he
in
asks
order
you
to
what is the distribution of the polyps? Is any specific part of the colon? Is it spared or not? And how that will help?
sorry, sir, I can't hear you.
So
What is the distribution?
Where are the polyps? So I showed you different parts of the colon. Yeah. Do you know what that part
Yes,
is?
sir. Yes, sir. This part looks like small ball, and the first most
Small
image
bowel.
is actually this one looks like small ball, sir. Is it?
No. What another
No.
thing? This is all colon, yeah?
This is all colon. Okay, sorry.
Yeah.
Yeah, this is all colon. Yes, sir. Large bowel, sir.
So yeah.
Yeah, this is a
What part of
cecum.
the-
Yeah, I can see the appendix as well. Yeah.
Nice.
Sorry,
Yeah,
yes.
good to hear. Yeah, that's a beautiful one. And then you can see that's the flexure. That's the rectum, and that's the sigmoid colon. Yeah.
Yes, sir.
Okay, so is the distribution sparing the rectum, and that's this is just a little bit rare, but this case turned out to be one of the polyposis syndrome. You don't need to know much, but this is Turco syndrome. You don't need to
Yes.
remember things, but you need just to say that you need screening. You need to make sure there's none of these are cancerous.
Yes. Breast cancer and medulloblastoma is associated more with the Turkic.
Excellent. That's what you need to use the association. And if you've got Piccios's syndrome, you have to mention about upper GI endoscopy to screen for other sites of the polyps and other sites of cancer. Yeah. So just as a refresher, this is a nice case. You can see clearly the polyps and distribution in different parts of the colon. And none of these looks malignant. So just to go through the picture, say I want to make sure that none of these looks aggressive or invasive or ulcerated, etc. They're just all well defined. This is a young patient. And but the main thing for that is to go for, as you mentioned, endoscopy and surveillance, and then looking for association. Yeah, excellent. Do you want to stay with me, or shall we take another candidate?
Sure, sir. No problem, sir. I can stay.
Okay, excellent. So I'm going to show you another lower GI study. So this is a patient who came for water control study, and unfortunately, I just to go through it one by one, but I'm going to get you the relevant pictures and load it up. And tell me what you see. So the patient had previous, I think that's the picture. So previous rectal cancer surgery, he had a diverging stoma, and now we send them to us to do water-soluble contrast study. So I'm going to stop in these pictures and tell me what you see. And then I'm going to try and load on the...
So this is post-surgical, right?
Yes. So for patients with rectal cancer,
yes,
we do some low anterior resection. and then you do water contrast diverting stoma, and then you do a study to see if there's any complication before we do the closure of the stoma. Yeah.
Sir, what I can see is actually a big diverticular formation,
Okay.
outpouching from the wall of the remnant of the bowel,
Okay.
with the accumulation of contrast within it.
Okay. What the
And
outpouching could be possible.
sorry, sir.
What
Sir,
could be what is
and sir, if I can request control.
okay? Request control.
Yes, sir, I requested.
Yeah.
Sir, yes, sir. So this is the outpouching which I'm talking about. And in the lateral view, this one maybe like it has very irregular margins that can give us a suspicion of either residual or recurrent disease.
Okay. I can't see your arrow somehow, so I'll just
Sir,
have to see. Yeah, I don't know why. But
can you see now?
really, I'm
No?
gonna have to, unfortunately. I don't know, can you move it or scroll the screen for me?
No, so I'm not able to get the control.
Okay. Now it says, yeah, that's you. So yeah, I can see you.
Sir, this is the outpouching I'm talking about. Like this is this looks abnormal.
Okay.
And in the lateral view, it has very serrated, irregular margins that
Okay.
makes.
So this is different from this. This is this. Okay. And then I'm gonna go to the lateral view.
Like there are two outpouchings.
That's
maybe.
earlier. No,
Yes.
that's part of the anastomosis. This is outpouching, yes, but this is actually part of the anastomosis. So
Okay,
it's
sir.
colorectal and anastomosis. So what do you think
sir.
that outpouching is? Could be possibly.
It's a diverticular formation.
What
with
else?
The outpouching with the recurrence and residual disease.
What else as a complication of surgery?
Leak.
Leak.
From
exactly.
Yes, sir. Perforation or leak from the site, surgical site. Sir.
Exactly. So that's the normal lower rectum, and that's our anterior section, and then you can see that's a colorectal anastomosis, and that's just a vestibular leak with pre-cyclic collection. Just you've seen it now, you know it. So if any history of surgery, you need to think about anastomosis and anastomotic leak, and that's one of the things we need to rule out when we do the water contrast. Yeah.
Yes, sir.
I'm going to show you one more.
Yes, sir. Sure.
In the lower side of things. And let's see if that will go right. So this is a Dane water contrast enema for patients who have trouble passing endoscopy. So somehow couldn't manage to pass the scope, so they ask us to do water contrast enema and see what's happening. So I'm going to put the most relevant two images for you and tell me what do you see and what do you think of this images.
Sir, sorry, this is post-surgical. I'm not able to hear the history. Sorry, sir.
No post-surgery. This is a patient who had lower GI, a little bit of lower GI bleeding. So they tried to do endoscopy, but they couldn't pass the scope beyond a certain point. So they asked us to do a water contrast study for that enema. Correct.
Okay, sir.
So I want you to just look at the images and tell me what do you see.
Yeah, sir. I can see the spot images of barium enema outlining. The outlining of the rectums appear okay, but as we go proximally towards the sigmoid colon, it shows a abnormal morphology in the form of like there's loss of there is a narrowing of the lumen, and there is especially in this area there is a narrowing and
narrowing, yes, and then
yes, and sir, especially in the sigmoid colon. Whole of the sigmoid colon appears to be narrowed, and there is proximal and distal holdup of contrast.
Okay. Not distal, I mean, it's proximal holdup, but I don't think it's holdup, that's normal colon, but okay. And there's
Sir,
some
it looks like a very smooth stricture, yeah. More of an inflammatory rather than a carcinoma.
Excellent. So we've got segments, so two segments. One is in that part of the colon, which looks okay now after distension, and then you look at that segment.
Yes,
So
sir.
what's your differential for that?
Sir, as it is a skip lesion, like proximal and distal bowel, or
Excellent.
looks okay. So first most will be Crohn's disease. And
Excellent.
I would suspect, sorry, ulcerative colitis, not Crohn's.
Are you sure?
Crohn's
What
disease.
is it
Sir,
Crohn's
Crohn's,
or
Crohn's, sir, Crohn's.
Okay, excellent. Why?
Skip
Just tell me
lesions.
why.
Because,
Skip lesions.
sir, because it is involving a part of it, not the whole of it. In ulcerative colitis, starts from the rectum and it travels upward in a very straight fashion, and there is a hostile pattern and in a continuous fashion. But the skip lesions are more often seen in the ulcerative colitis than Crohn's disease. I'm talking opposite, sorry. Skip lesions are more often seen in Crohn's disease than ulcerative colitis.
Excellent. That's fine.
So I would like to investigate the whole of the gut to see for any other skip lesions.
Excellent. So that's a case of Crohn's disease, as you mentioned.
Yes.
And just a nice case for that. Demonstrating for this patient. Let me think about, I'll show you another companion case. Just to get that in contrast with X-ray, to reverse to X-ray, we can get a comfortable. Very careful. We'll continue, but I'm going to share screen again. And tell me, this is a plain X-ray of abdomen. Tell me what we see. Patient coming with abdominal pain and diarrhea.
Sir, X-ray abdomen, frontal projection, in which I can see that the most prominent abnormality is actually in the left side of the X-ray, in which I can see the large bowel outlined by the gas, and in which I can see the mural thickening and the lead pipe appearance, sort of like a hostile appearance of the bowel, and there is mural thickening, and there is a suspected stricture in the descending colon.
Okay.
And there is proximal dilatation of the whole of the large bowel and also as well as of the small bowel.
Okay. I don't think so.
Yes,
It's
sir.
just gaseous distension. Would you call that
Yes, sir.
obstruction? No.
No, sir, I wouldn't call that
Okay.
obstruction because
Okay, so,
yeah.
fine. So it was not dilatation, just gaseous distension. So
this
do you think
part
that's the
looks
case?
abnormal. So this part looks abnormal. I would like to confirm whether it is involving through and through and extending till the rectum. And if
Yeah.
it is, then I will call it ulcerative colitis because it has this
Excellent.
mural thickening and a hostile pattern. Otherwise, I would go for I would also suspect Crohn's disease, and I would like to take the history of the patient to rule out pseudomembrane colitis as well.
Excellent.
So,
Okay. This is a young patient. So this is all good differential. This is left-sided colitis. And this is a case of ulcerative colitis, but you need to make sure, as you mentioned, other causes of left-sided colitis. But the last one, aside from pseudomembranous, is ischemic, but that's not the story here anyway. But that's under differential. So thank you. That's very well presented.
so pseudomembrane
Very
colitis is ischemic.
No, yes. So I mean, the Clostridium difficile, that's another thing. But
Okay, sir.
yeah, so that's a different story. But in this case, is ulcerative colitis, as you mentioned, the bile is a long segment in the left colon extended to the sigmoid. You can't really characterize that, although the sigmoid, you can see this loss of frustration compared to the rest of the bowel. It's a young patient. And as you said, there's a thickening, renal thickening of the, and this is a case of ulcerative colitis. And you walk through the differential, and what you do next for the patient?
For sir, MR enterography.
Okay.
Or CT enterography too.
And to do what are you doing the MRE for?
Sir, in order to know the extent of the disease, the associated complications, and to know whether it is active or not,
Yeah, exactly. But it's mainly the endoscopy is the main thing. MRE is reserved for Crohn's, but if you did an endoscopy and we suspect that there's element of Crohn's, you might need to do MRE to exclude small bowel disease. That's what you want to do. Just make it clear in your presentation why you're doing. If you're ordering another investigation, do MRE to make sure not exclude small bowel. And endoscopy to see. So that's and surveillance, of course, after starting the treatment. because there's a high risk of cancer in general. I mean, we got beyond an hour. I don't know if people want to take a comfort break or happy to continue. Happy to continue. Just moving that part from the flouroscopy to some X-rays, interesting X-rays. Although I have one more actually, flouroscopy before we go. Right. Hopefully that will be easier to show. Why don't you stay with me and I'm going to show you another case, yeah?
Sure, sir. Sure, sir.
Okay, so hopefully. So this is another study. The patient is complaining of difficulty in swallowing. Very young patient, yeah. I'm going to run it through. That's the lateral side. And tell me what you see. Sorry, this is just a mistake on this side, the way the images was transferred. Just here. What do you think that appearance of?
There is an extra luminal indentation.
Okay.
Like it's a very smooth structure in this area. If I have the remote.
Yeah, you can request if you want.
Sir, this area. You can see my arrow, sir.
No, I can't, but I can stop and tell you. You have the control remote. Sorry. Okay, you see the smooth narrowing, yeah? Anyway, that's
Yes,
right.
Here, yes, sir. Sir, it
Okay.
more appears like it's a vascular thing.
Okay.
Like it's a very smooth, it's a very smooth narrowing with no mucosal irregularity. So like it is an indentation from the outside.
Okay.
It can be vascular. It can be a secondary leiomyoma of the esophagus.
Okay.
But in this area, in this part of the chest, my top suspicion would be a vascular etiology, an abnormal vessel.
So what kind of vascular? What abnormal vessel?
Sir, aberrant subclavian artery.
Excellent. So yes. And do you know what the name of this case? What we usually call it?
Name? This
Yeah. Yeah. The diagnosis of this. The medical name for it. It's called
the right-sided aortic arch with
dysphagia lusoria. And we did a CT.
Yes, sir. Dysphagia lusoria. Yes, sir.
So, and that's a CT thorax done for a different reason. And you can see here.
Yes, sir. I can. Yes, sir. Exactly.
And you can see that the esophagus just at that time is compressed between the trachea.
Yes, exactly. It's passing behind the.
So this is a case of dysphagia lusoria.
Lusoria.
Yeah. There's barium fall through. I don't think we will gain case of that, but I'm just showing you some cases of just for your interest. And again, I'm going to ask you another question. But as you can see, this is barium fall through, and you can see there's a terminal ileum structure, just in case you become something like that. But also there's a sigmoid stricture, which is killing with Crohn's disease. But we might not get this. It's a sigmoid stricture and the terminal ileum structure. This is multiple colonic stricture, Crohn's colitis. Again, we show you common cases in uncommon sites. That's a theme for the 2B. So Crohn's usually come in the small bowel, but it can come in the colon. You can see multiple colonic structure. That's a study by for 3. From that, and then I'll show you one last thing, a couple of things. Do you know what that kind of a study is called?
The proctoscopy.
Or proctograms, yeah.
Proctogram, sorry. Yes, sir. Proctogram.
So evacuation. Yeah, evacuation program. What do you see here? What is the abnormal finding?
Sir, there is a filling defect in the proximal part, like a soft tissue filling defect that has a regular.
No, that's fine. That's a fecal matter, but that's a good thought. What's happening here in the anal canal? It's a difficult case anyway. I'm just showing for interest, just in case, but I don't think it'll come with 2B. Again, how to deal with the unknown. But what do you think that is happening here?
There is a prolapse of the rectum.
Exactly. So we might show you the case again, how we think about it. It's not a problem here. As you said, there's a feeling defect. Could be fecal
Yes,
matter, could be anything, but there's some abnormality here.
rectal
There's that
prolapse.
mucosa. And then if you go to the end, you can see that. So that's a rectal prolapse. And let me show you this one too. Another one. Just in case. What do you think is happening? What abnormalities?
The rectocele.
Yes, anterior rectocele, and as you can
Anterior
see,
rectocele.
and it's just relapsing through the vagina. Just another one.
This is again a sort of prolapse with the rectocele both.
This is a small bowel. You take give oral contrast, and that's anterior, but small bowel relapsing through the perineum. So it's just a rare case, but just in case you go through, and this is another one, just in case you get it. But what do you see here? What do you think about that one? I'll stop here. What abnormality do you see?
There's an outpouching along the anterior wall.
That one, okay, that's indentation, that's fine. What about the posterior wall? See that?
There's a stricture, this narrowing.
No, it's not stricture, it's an ulcer.
Oh, okay, ulceration. Okay.
Yeah, and the differential is either solitary rectal ulcer or rectal cancer. So sometimes you see it random, but this is solitary. We'll stop here. And that's the fluoroscopy things. We're going to move a little bit. Are people happy to continue or take a break? People happy?
Sir, I think candidate 1 is back.
Okay. So we start with candidate 1 then. I'm going to do some X-ray now. Abdomen. All right, candidate 1. This patient presented with abdominal pain. Candidate 1, can you hear me? No, okay, or can move to candidate 4. It's been quiet for a while.
So she cannot unmute herself.
Okay. Who can unmute other than candidate 3? Candidate 4 or candidate 2?
Yes, I can.
Okay. Okay, candidate 4.
Now I
your
can
voice.
unmute. I'm
Yeah.
candidate 1.
Okay. Can we take candidate 4 and stay with me, candidate 1, and then we'll take so candidate 4.
Yes.
Just because this is a patient presenting with abdominal pain. What do you think?
I have been provided with a frontal ETO of an abdomen of an slightly mature patient. Here I can see that there is evidence of soft tissue density projected over the center of the abdomen, which is displacing the bowel loop upwards. And there is evidence of some calcification is also present within this soft tissue opacity.
Okay.
Oh. The bowel loops are appear displaced upward. There is no dilatation of the bowel loops noted.
Okay.
And,
can you describe a little bit more about the calcification?
The calcification is a type of curvilinear, and at the lower aspect it is a curvilinear.
Okay.
And
so what causes this appearance?
Oh, is it? Like it is a marginal calcification. Oh.
Okay. What's your differential? What could cause this appearance?
This can be some calcified mass within the abdomen.
Okay. So it's a pelvic mass pushing the abdomen up, yeah? So what pelvic masses has calcification?
On pelvic mass with calcification, this can be if patient one is a neuroblastoma which has associated with the calcification, but this is not the age of the patient.
Okay.
Other dermoids like pelvic mass can be present with the calcification.
Well, okay. I'm gonna put you some misery. If I said to that's a calcification, that looks like a spine. And that looks like a head.
Is it a fetus?
Fetus, yes, fetus. This is an X-ray. Unfortunately, doesn't happen again. Will never happen again. Of a pregnant lady. We need to see calcification of the head, and we need to see that's the spine, a little bit of ribs. So this is an X-ray of a fetus, unfortunately, where the abdomen, and there's no bowel obstruction in this case. There's some constipation, but there's no free air. So I want you to, when you look at the abdominal X-ray, sorry, this is just one of the rare cases. I want you to go the approach. First, abnormal gas, dilated. Is it small or large bowel? Is it inside the bowel or outside the bowel? And then you look at for abnormal calcification. What is the pattern of the calcification? And then you go for a bone into tissue. So I think that's how we look at X-ray. Very simple. But as I said, there's a pelvic mass. There's calcification. This is fetus, fetus basically. Unfortunately, they get radiation with the X-ray. All right, gonna move on. That's okay with you. Stay with me. Then there's another X-ray of a patient with abdominal distension.
I have been provided with a frontal radiograph of an abdomen of a patient who is presented with a complaint of abdominal distension. Here I can say that there is evidence of dilatation of the significant dilatation of the bowel loop is noted within occupying left side of the abdomen.
Okay.
It is quietly distended, and there is a convergence of a line is noted at the lower quadrant. And the adjacent bowel loops are also appears dilated.
So what bowel loops dilated?
These are the large bowel loops dilated. Adjacent to the large bowel are also dilated. So I'm thinking in terms of some sigmoid volvulus. I have to differentiate from cecal volvulus, but in the cecal volvulus, there should be no dilatation of the large bowel.
Okay.
And
so you think this is large bowel dilated? So can you see this is coming all across?
Okay, so these are the valvular canal.
And you can see that's the rectum and sigmoid. And then you can see the colon here.
Okay, so these are the small bowel loops are dilated within the abdomen.
Okay. This is dilated small bowel loops. This is a bit difficult case. But the large bowel actually is not dilated. So if you see all this dilated small bowel loops, what are you thinking about?
This can be due to small bowel obstruction. And there are many causes like some obstructive mass lesion. Some paralytic ileus can be a cause of the obstruction. And some ischemic bowel loops can also be like ischemia, one of the cause of obstruction.
Okay. I mean, ischemia is a subsequently of the obstruction, isn't it? Is a result of the obstruction from the ischemia and perforation. So when you look at this, small large bowel is a small bowel dilated. Any evidence of free air in the abdomen? That's what you need to mention. No, I don't see any. But anyway, that's what you should do your system. And then what's your next step in this case? So your differential is.
Yeah, the differential are this can be due to adhesion, this can be due to hernia, this can be due to some obstructive mass lesion.
Okay.
So I will advise further contrast in a CT scan of the abdomen to rule out the cause for the obstruction.
So we're going to rule that. Unfortunately, we can scroll it through, but I will just run it to you and tell me.
Okay, there is a significant dilatation of the bowel loop. There appears to be a thin walled.
Yeah.
I'm going down.
So what are you looking for? Just talk me through.
I'm looking for the transition point of the obstruction.
Okay. And you can see the large bowel all collapsed here. So I'm going to just, there's no transition point. There's some small bowel loops collapsing right leg fossa, you can see here. But this is a case of something called the Steinern pseudo-obstruction. The learning point from case is just to differentiate large from small bowel dilatation. As you said, it could be ileus, hernia, adhesions. There's also different causes for small bowel obstruction. Yeah.
This is a paralytic ileus. There's no obstructive.
So there's no cause of obstruction. There's paralytic ileus or something called the Steinern pseudo-obstruction, which is chronic intestinal failure. So that's a case of Steinern pseudo-obstruction. Stay with me. What do you think about this case?
Okay, I have been provided with a frontal radiograph of an abdomen of a skeletally immature patient. Here I can see there is a NG tube is noted, I think depending the stomach. There is also umbilical artery, catheter is also visualized. And here there is evidence of a large air-filled gaseous distension is noted and it is occupying whole of the abdomen. This is suggestive of pneumoperitoneum, and the small bowel loops are appears dilated. I'm looking for if there is any evidence of nematosis intestinalis. Here I could not find, but there is a pneumoperitoneum and the bowel loops are appears dilated in this. Okay, and I can see the bowel loops are also seen at the left inguinal region. So this is likely a inguinal hernia.
Okay.
Yeah.
In this case, I mean, it was complication. As I said, this hemoperineum complicated neck, basically, sympathizing into the glotis. Yeah. So, okay, for this abdominal X-ray.
I have been provided with a frontal radiograph of an abdomen of a skeletally immature patient. Here I can see that the bowel loops are appears slightly dilated in the abdomen. Oh, I could not find any evidence of free air. There is no evidence of nematosis intestinalis.
Okay. Are you sure there's no air in the abdomen? Free air in the abdomen?
I could not find like the there is no any sign of regular sign or.
What do you do next if you want to make sure there's no air on the X-ray?
I will lateral decubitus can be done, or otherwise ultrasound of the abdomen can be do for further confirmation.
So ultrasound is the proper way we do it. That's true, and you can see some free air in that. But we do the lateral exactly. So what do you think about the lateral?
Here I can see that the air is lie at the anterior of the liver, so there is a pneumoperitoneum.
Exactly. So that's one way or another to ask for another view. If you're not sure, you do a lateral, but you can see some air in front of the liver here and around the liver, outlining the liver. You see that? That air is outside the bowel. That air also projecting on the liver. But maybe that's the more clear. That's not inside the bowel. And that's just suspicious. And then when you do the lateral, you can see it clearly. So that's another subtle case. So this is obvious case of pneumoperitoneum. This is a subtle case of pneumoperitoneum. Okay, excellent. Can we have another candidate, please? And I'm going to just stop sharing for a second.
Yes, sir.
Okay, I'm going to load different cases now. I think this is an interesting case. Okay, what do you see? Two X-rays, I'm going to put it next to each other. Oops, that's not what we want. Okay. So this is patient who came to A&E complaining of abdominal pain. Well, if you want more history, I can tell you, but you can tell me what you see.
Sir, I am provided with radiograph abdomen of skeletally mature patient. I could appreciate a dilated bowel loop in the pelvis with its projecting towards right hemiabdomen and converging towards the three converging lines converging towards the pelvis. In addition to that, I could also appreciate large bowel loop dilatation. So there is scoliosis of spine and degenerative changes, and I could see few densities. I'm thinking of sigmoid volvulus with a coffee bean sign and a converging line sign, and would like to convey my findings to the primary and take a surgery consult.
Okay, thank you very much. Okay, let's stop a little bit and slow down. I think it's important to give a little bit of space. So summarize the findings so far in the bowel. You said there is large bowel obstruction, yeah?
Yes, sir.
Okay, any free air?
I could not appreciate any.
Okay, that's just assessing. Yeah, that's important. Okay, what other causes of large bowel obstruction?
Sir, large bowel obstruction could be due to some cancer or obstructing mass, any hernia.
Obstructing mass will be cancer. Yeah. Okay, hernia. That's the second thing.
Yeah.
Okay. If I told you there is a cause on this X-ray for the large bowel obstruction, what else could be?
Is there anything in the sigmoid at the junction of descending or sigmoid colon? I'm not sure.
Okay, so I mean, ideally, when you describe bowel obstruction, small or large, you tell me what bowel is dilated. So let's go back to the large bowel obstruction. Tell me what part of the large bowel is dilated.
So the descending colon, the sigmoid colon.
Is the sigmoid dilated?
So I
So
think so.
what is that? Let's start again. What is that?
So so is it cecum?
That's the cecum, and that's a transverse colon, and then stops
Ascending
here.
transverse, so sigmoid colon is not dilated.
Okay, excellent. So let's go thin. So what other things on the X-ray you can see?
A few surgical staples.
Okay.
So maybe some cancer.
Okay, we talked about cancer. What other things? Okay. And you can see surgical clips, so it could be adhesion, but this is like sterilization clips, you shouldn't really. But what else on this X-ray? Let's focus on this X-ray. Can you see something? Or what you do next anyway?
So CT scan.
Okay, I'm gonna move to the CT scan and we'll keep that X-ray here. Or just I'm gonna be in the CT scan. You can ask to scroll, or I can scroll it for you quite quickly.
So please scroll down for me. I could appreciate left-sided pleural effusion. With mild right-sided pleural effusion as well. I could appreciate the gut was herniating.
Excellent. So I'm gonna just reconstruct that for you.
Sure.
I think you'll appreciate it more in the corner, so it takes some time. And hopefully it works soon. It's loading. Yeah. Okay. So the only history of this patient is 10 days ago he had an accident.
There is herniation of large bowel through the diaphragm into the chest wall.
Okay.
So is there any history of trauma or something?
Yeah, well, he's just told us that 10 days ago he had a car accident, but he never got to the hospital. He just had some left-sided pain.
So I'm thinking of some.
You can see some rib fractures here too.
Yeah, diaphragmatic rupture with herniation of the large bowel, causing this obstruction. Type 4 hernia, I think it is.
And what do you see this?
The bowel is hyper-enhancing, so I'm thinking it's being strangulated.
Excellent. And we don't see any free air. So just a systematic approach. We see bowel obstruction, the bowel is herniating, strangulation. This is all part of your presentation system, yeah? So that's a traumatic. If I went to the X-ray, can you see that now? You see that left hemidiaphragm is gone.
Okay.
And there is a lot of fusion. I mean, what I wanted to you're not going to diagnose diaphragmatic hernia from this X-ray, but definitely there's a problem in that. There's a small right effusion, but there's a problem in left hemidiaphragm.
Okay.
And then he asks, and tell you the history, there's a trauma, but this is not a sigmoid volvulus. So you need to just be careful when you look at the pattern of the bowel. This is the cecum, this is transverse, maybe left colon, but we'll lose the outline here, and that's probably transition point, probably something happening here. So it's something the left side of the colon in general that gives me this problem. And then that means sigmoid volvulus is out of the way. Could be cecum, could be something else. But it helps to, what I'm describing the bowel obstruction is to know where the site of obstruction is. I'm going to show you just to combine in case. I'm going to make it into a story. You're sitting down in the reporting room, and then you're doing a CT colonography. And then when they do the scoutogram, the radiographer come to you and say, we've seen this. What do you think that is?
So I could see the large bowel protruding into the left chest cavity. The left femoral hip replacement was also seen. I would like to see the CT scan images to see the
yeah. So it's just the whole colon is there. It's just herniating. And what information you need to know from the scan?
So the large bowel is protruding in the entire chest cavity.
Excellent. Well, what we need to know when the CTC is happening is just put in the lung window and see if there's any bowel perforation. Okay? That's very important. So you put it in the window. It helps you to show where is any perforation or not out of this. Because if the perforation, then we're talking about surgical emergency. Yeah.
Yes.
So that's important.
So
Somebody
I
had
could
it for
not
you.
see any bowel perforation.
There's no bowel perforation, there's no bowel obstruction at all. This patient had it for many, many years, never been symptomatic, but with that, but as you can see, this is just large hiatus hernia. So definitely thing, but that's congenital more than traumatic one. Okay. Do you want to stay with me or?
Yes, sir.
Okay, shall we keep in the pattern of bowel obstruction? Perhaps I'll show this case. And then we swap. We'll show another case and then we swap cameras. So what do you see about this X-ray?
Sir, I could appreciate that there is a few dilated bowel loops seen in
Okay.
the periphery of the abdomen. I could not appreciate any free air.
Okay.
The no bowel loops in the no rectal air is noted.
Okay. That's
In
good.
addition to that, the large bowel seem dilated.
Okay. So large bowel dilatation, there's no free air. Good.
In the
Then we look for causes. What is
Yes.
what large bowel is dilated?
So I think the cecum ascending, the
Okay.
descending as well.
But then stops, yeah?
Yeah.
So what's your differential?
So maybe sigmoid colon cancer or
Okay. The same that what we talked about. So
yeah,
cancer, hernia,
hernia.
adhesions, yeah.
Okay.
Adhesions, that's that common. But a hernia to obstruct large bowel is usually very rare. It's just obstructing small bowel, but it can obstruct large bowel. So that's the colon. I'm gonna scroll up and tell me what you see.
Sir, I could appreciate. Can you please scroll down? Yes, I could appreciate some. The rectal sigmoid junction is collapsed,
Yeah.
and I could appreciate few divertically
Excellent.
along the sigmoid colon. So maybe it's complicated diverticulitis.
What else? But you see that
Or
thickening here?
or yeah, or could be it could be some malignancy.
It is, yeah. Okay. This is malignancy, and we can see
Okay.
some small air
Okay.
here, which is a little bit an ominous sign. But
Yep.
could be inflammatory lesions from diverticular disease, could be cancer. It's cancer, it turned out to be cancer. We did surgery on the size it's a small cancer. But the differential could be an diverticular. But that's a stricture and upstream bowel dilatation, yeah? And what you look for is free air, portovenous gas on the CT. This is just a system in your mind. You have to
Yes, and
go
meds,
through.
any possible meds in liver and other
Exactly.
abdominal
Look for
viscera or
that.
bones.
Exactly. We do next week. We'll do some cases of acute GI, and that would be much more straight. We'll talk about these sorts of things. But what I want you to see here in the X-ray, large bowel, what is the pattern, and if any intra-abdominal, extra-abdominal air, and then where's the site of it, and then that will tell you the diagnosis and the differential, and then you go to the next step, and then you discuss the next modality. That's what happens in the exam. So I'm going to show you another abdominal X-ray. Hopefully,
Okay, sir.
yeah, and then tell me. So this patient becoming with abdominal.
Sir, I'm provided with a radiograph abdomen. I could appreciate multiple air lucencies in the retroperitoneum and outlining the descending colon. So
Okay.
I'm thinking of retroperitoneal air. In
Okay.
addition to that, I think that the large bowel loops are dilated.
Excellent. So what are you going to do? So large bowel loops dilated, not dilated, it's fecal
No,
loading
not so
in
much
general.
dilated.
Yeah. So describe your findings, summarizing what you're going to do next.
Sir, I'm thinking of pneumoretroperitoneum, and I would like to search for any cause of that, and I would see any concurrent pneumomediastinum as well. The pneumoretroperitoneum could be due to injury to ascending, descending colon, or any other retroperitoneal viscera. and I would like to
Okay.
do further a CT to evaluate the cause.
Excellent. Okay, that's fantastic. Done really well with that one. So I'm going to scroll.
Sir, I could appreciate that descending and transverse colon are dilated, and the ascending and transverse are dilated, and descending is collapsed.
I don't
Can
think
you
it's dilated. It's fine. That's all within normal range.
Okay.
But I'm just going here. That's your.
But there is, I
point.
think there's a perforation with with the leakage of fecal matter in the sigmoid colon.
Excellent. And that's leading to retroperitoneal there. So
Yeah.
sometimes you get what was called antimesenteric perforation, which leaks the air in the mesentery, and that can cause retroperitoneal. Well, although it's a sigmoid, it's intraperitoneal, but because it's perforated into the mesentery, so it can cause retroperitoneal gas. Well done in doing this, guys. We spotted it's very subtle abnormality. So I'm going to go through the X-ray again. But again, as you said, this is all fecal matter outside the bowel lumen. And this is all air outside. And that's a case of retroperitoneal perforation from ruptured sigmoid, even a reticulum. But it's the whole wall of the give away. And you can see this is outlining of the psoas, not as in the right size. So just be careful with this. This is very important X-ray in the exam. Excellent. Well done. Can we have another candidate? So thank you very much. We've been amazing. Stop sharing for 2 seconds, and then if the other candidates tell me, we can start sharing again. Who is the candidate? Next candidate? Hello.
Yes, sir, I'm.
Hi. Okay. Sorry. All right. This is a patient coming again with abdominal pain. Tell me what this is. I can give you a little bit more history, but you have to ask me.
Yeah, so I can, these are two frontal projections of abdomen and pelvis, and
Okay.
I can see that there are two intrauterine devices I can see, and I can see a tubular structure in the cecum.
Okay.
Um,
What do you think?
So can it be a foreign body or
Okay. What else?
a worm?
Okay. A big one. But what do you think? Okay. What is the state of the bowel? Is any bowel obstruction? Just go systematic through the X-ray, and then we can talk
Yeah.
about this better.
So I cannot see any free air.
Okay.
There is a small bowel dilatation, air-filled
Okay.
bowel loops are noted.
Which you mean this? That's
Yeah.
fine. That wouldn't worry too much. Okay.
The ascending colon, transverse colon appear fine. The descending colon is also not dilated.
Okay.
So
So,
these are the two bios.
So there's no
Yeah.
bowel obstruction. There's contrast here. You can see nicely the appendix too. There's something there on the right iliac fossa, but no one is that. So the patient have chronic constipation since he was a child. Why the patient have two intrauterine devices?
So this can be a biconvoid uterus.
Okay, it's not backward.
So this can be a
didelphys.
misplaced
No,
IOCT.
uterus didelphys, yeah?
Yeah,
The
uterus
patients
didelphys.
have two uterine, basically. And the usually subfertile, not infertile. So these young people still have pregnancies. So we've got 2 IUDs. And this is something we call a chronic constipation, see fecal loading, but there's no bowel obstruction. There's some dilated bowel intervention, but that doesn't indicate bowel obstruction. We have an NG tube. And this is something called cecostomy, which is an old operation done for young patients who have constipation where they can do antegrade enema. I'm not expecting you to know that, but he just spotted it and just explained that some congenital anomalies. You can see also the sacral malformation. You see that? So this is all part of
I
the
cannot
congenital.
see the gas in the pelvis.
Exactly. So this patient have a lot of congenital anomalies. Part of it is sacral malformation, uterine didelphys, chronic constipation, bowel opening. And then also, we have the cecostomy, which is part of the management, which we give antegrade enema through it. Obviously, it was not working. We were looking at this displaced or not. Okay, excellent. Thank you. I'm going to just stop share and share again. Stay with me. I'll show you another X-ray and tell me what you see. This is a patient coming with acute abdominal pain.
Okay, I'm presented with a frontal projection of an abdominal radiograph, and I can see markedly distended gut loops.
Okay.
Yeah, the whole of the colon is distended, and I can see there is an element of pneumatosis.
Okay. Where's that?
On the right side.
Excellent. So you see that air here.
Yeah.
Ball. Okay. So what do you think?
So this can be ischemic bowel.
Okay. So that's ischemia in the part of the cecum, yeah? The cecum is largely dilated.
Yeah.
And what is the causing of the large bowel? So what part of the transition?
It's quite redundant.
Yeah. Okay. Because it's distended, it's obstructed, isn't it? So you can't see much gas in the rectum, but you have to go through the whole thing again. Is it cancer? Is it hernia? Is it adhesions? Likely could be from cancer or diverticular disease. Yeah. But what I wanted to show this X-ray is from this pneumatosis here, which is quite nice. And that's urgent, because that's indicative of bowel ischemia, yeah, from the cecum, which is risk of rupture and perforation. Yeah. So what are you going to do next?
CT.
CT. So we're going to do the CT. That's the CT. I'm going to just show you quickly. You can see there's a lot of fluid, which is not a good sign. And you can see the dilated bowel loops. And then you can see this is the pneumatosis. We're talking about the X-ray, which was beautiful. Yeah. And then tell me when to stop.
So, yeah, I can see a stricture, in the sigmoid.
Yeah, so that's where the site of the obstruction is.
Yeah, this is the site of obstruction, and there is proximal dilatation of the colon.
Yeah, excellent.
Yeah, this looks like an apple core lesion.
Excellent. So that it's a sigmoid, distal sigmoid cancer, basically, causing upstream dilatation. What would you do next?
So next would be a colonoscopic biopsy.
You think? What else in the... No, I mean, you've seen pneumatosis, yeah? You're raising, and there's a lot of fluid. So what do you think will happen next?
So urgent surgery to secure the bowel.
Exactly. Yeah. So you do Hartmann's, you do diversion, then you deal with the cancer, but you can't leave that bowel for colonoscopy, that's for sure. But what else you see here is massive laterals also. This.
Yeah.
So that's going to be difficult. So you've got cirrhotic liver also, which is not a good thing. But you can see very chunky portosystemic canalization of the umbilical thing. So yeah, quite beautiful. Those spikes. That's what you need to spot when you do the CT to tell in the cirrhotic liver, because once they try to do laparotomy and they open the umbilicus, all that will be bleeding. Yeah, that's all very nice covered with those there. But anyway, that's the side effect. Anyway, that's an important finding. But what is important here is you spotted the pneumatosis in the X-ray, and that's eminent for causing ischemia in the CT. Okay. What do you think about this X-ray? Although I'm going to try to see if it projects well. There's another X-ray of the patient who presenting with abdominal pain.
So this is X-ray frontal projection.
I could play with the contrast, would be better. Yeah, go for it. Oh, sorry. Oh God, that's my mistake. Give me 2 seconds. Okay, go for it.
Okay, this is an X-ray frontal projection, and I can see few loops of bowel.
Yeah.
They do not appear to be dilated. I can
Okay.
see a radio density overlying the right pelvis.
Okay.
There's paucity of gas in the pelvis.
Okay. What does that mean when you see positive gas?
I cannot appreciate gas in the anorectal region.
So what you see, so trying to summarize, you've got density here.
Yeah.
What else? You've got, what do you think about these bowel loops?
So these bowel loops are they're not distended actually, but
Okay.
the bowel loops in the left side, they are they're small bowel loops and they are closely packed, valvulae conjunctae.
Yeah, so that's dilated small bowel loops. It's proximal small bowel obstruction. So do you see any gas outside, any free air, and any gas anywhere else? And what is
I can
that?
see some gas lucencies in the pelvis.
Okay, that's fine. Anywhere else?
No, I cannot appreciate any other free gas.
Okay. What about this density and how is it related to small bowel obstruction? And if you don't know what do we do next?
Can it be a gallstone ileus?
Okay, and what helps you to establish that diagnosis? Other than CT, I mean, in this X-ray?
If there is pneumobilia or...
there is, yeah, that's why I was trying to make it a little bit obvious, but can you see the pneumobilia?
It's a bit blurry, actually,
Yeah, it's not a great image, but I should have be able to load it. But you can see there's air here in the liver. There's air here. There's air here. But that's
now I can appreciate.
Yeah, and then you can see that's a small bowel dilatation, and you get concern. So gallstone ileus, you do next. You do CT abdomen anyway to see what's happening, and then you can see the pneumobilia is a bit gone in this case. There's a little bit still some very minute one, but that's fine. And then we can see that's the gallstone.
Yeah.
And then proximally the bowel is dilated, a little bit lost of the dilatation that in this case. But this is a case of gallstone ileus. Okay, but that's a classic X-ray that you'd expect from the exam. It's very cool. Okay, I think we're nearly time, so I'm gonna pick up a couple of more cases. Are you happy to continue, or shall we have another candidate?
Yeah, I can continue.
Close to me, so what do you think about this? Hopefully not confusing you much.
This is a frontal projection of pelvis.
Okay.
I can see there is a large air-filled viscus in the middle.
Okay.
And dilated colon around it.
Okay.
Could it be a volvulus?
Okay. What else? I mean, everyone's thinking about volvulus. I'm intentionally not showing you any volvulus today, because I think you've seen it already many times. So what else? So you see the colon, that is colon, yeah, distended over whatever is there. Do you see small bowel dilated?
Yeah, I can see a few loops on the right side.
A little bit, but not very impressive, isn't it?
Yeah, not much. Yeah.
And the large bowel itself is not really impressive.
Yeah.
So what else could be?
Can it be a large cyst or?
Okay, could be. What else? For this area, this is air inside the bowel, yeah?
Yeah.
So what could be else part of the bowel that looks like that?
It is can it be an abscess?
Okay. I said this is within the bowel. What could be other bowel loops, do you think?
Okay, within the bowel.
Yeah, sorry.
Cecum?
Okay, that's the colon here, and that's the cecum here. But if the cecum is like that, you would expect the small bowel. I think the cecum, by this way, should be ruptured, isn't it?
So can it be stomach distended?
Yes, and if that's stomach, what would be your diagnosis? What's your differential? Why is it
A
stomach?
distended stomach could be due to pyloric stenosis. It could be due to a mass. It could be due to
so gastric outlet obstruction. Yes, so volvulus, gastric outlet obstruction, and gastroparesis. That's another thing, which is functional obstruction, basically. But you can see this is the colon, it's not dilated. It's cecum around here, small bowel is not dilated. That leaves you only the stomach, basically. This patient with gastroparesis, but you can see they appreciate that. Sorry, that's not the right. This is obviously the CT. That's how the stomach come out. And that's how just the shape of the patient. Once we put the NG tube, stomach is deflated and everything looks a little bit back to normal. So this is a bit exaggerated example of that, but you can work yourself through it. Large bowel is not dilated, small bowel is not dilated. It looks like maybe a cyst, but it looks like there's a wall around it. Could be just distended stomach, basically. It's a bizarre and weird one, but again, you can still work yourself through it. Yeah. I'm just conscious of the time, and I wanted to show you one of my favorite cases. So give me 2 seconds. Stay with me, and then do one more case in X-ray.
Okay.
And then if people have it to stay, I can have 2, 3 more cases, but if not, I'll just okay. I'm going to share now screen. This is a really nice case. Not necessarily related to the abdomen, it's a pediatric, but again, there's a lot of fun. Oh, sorry. 2 seconds. Yeah.
Okay, this is a frontal projection of a skeletally immature patient, and I can see multiple dilated bowel loops. There is a ETT, which is quite low.
Okay.
And there is a pneumothorax on right side.
Yeah. What about the left side?
Yeah, also on the left.
Okay. Just try to be systematic. Let's look at lines and tubes first, and then Let's see. Because there's a lot of finding here, literally everything. Yeah.
So there is bilateral pneumothorax, there is a malpositioned ETT.
Okay.
There is another catheter. Is this umbilical
Yeah.
venous catheter, and it is also
Malposition.
malpositioned.
Yeah. Where is it going? Where's the tip?
I think it's going in the portal.
Portal vein, right? Left portal
Yeah.
vein. Exactly. So you should be in the IVC. Okay. And risk of thrombosis. So that needs changing. What else? Any other tubes?
I can see two tubes.
There's one here.
Yeah.
Yeah.
Yeah,
What
there
is
is
that?
another one there. Yeah.
What is that? What do you think?
Is it a central line and there's air lucency around it?
No. We'll try it. Have another thought.
Can it be NG tube and it is coiled?
Okay. So keep that observation. Okay, let's go in the chest. You see bilateral pneumothorax, yeah?
Yeah.
What about the abdomen?
There are multiple distended gas-filled loops.
Okay.
And I can see the regular sign.
No, there's no free air. So I don't know whether you can see it. I mean, that's a bowel around the lumen. It's bowel around the lumen. It's not much really free air anyway, but yeah, it's distended bowel loops. This is obstructed. But what's happening with the rectum? Trying to help you.
Yeah, there is a sacral agenesis.
Okay. Well, malformation, yes. Agenesis.
Yeah.
Do you see any rectal air?
No, I cannot see any rectal air. There seems to be anorectal malformation as well. So this could be a vectoral anomaly.
Okay. So putting all together.
Yeah, putting all together, this could be a vectoral anomaly.
Yeah. So what do you think about this tube? Why is
This
it
is,
called?
yeah, esophageal atresia.
And which type?
And there is a distal fistula, C
Excellent.
type.
Okay.
Yeah.
So it's distal fistula because there's air in the bowel.
Yeah.
This patient has clinical anal atresia. It's a vectoral case, cecal malformation, abnormal shapes of the chest and the ribs. All the lines, the two lines are not in the position. That we should be aware of that. So what do you do next?
Next, so there should be further evaluation. There should be evaluation for the cardiac anomalies.
Okay.
For the renal anomalies.
Excellent. Okay.
Yeah.
Cardiac anomalies, renal anomalies, just part of the factor. You just have to go through it. We're talking about tracheostomy and fistula here. Thank you very much. Well done. So that's the case again of factual. I mean, it's a little bit outside the abdomen, but you can see there's a lot of findings in the chest. But I thought I would share that with you guys.
Yeah.
Okay, thank you very much. I think it's just we do time. Just wondering whether people are happy to keep going, or I think I showed you most of the interesting cases in general. But I think, and just to conclude, really, so in the fluorodon, it's all basic, you know, all they have the knowledge. I think all the candidates did very well with that. Nothing to be scared of. Some contrast in the lumen. This is not meant to be there. There's anaphylactic defects and adhesions. So we went through a lot of diagnoses in a lot of cases. And we've gone through the abdominal X-ray, just to have a systematic approach and be confident, and just how to deal with the unknown, to have a way of thinking about it. And you don't have necessarily to think about the diagnosis, but think about the approach, differential diagnosis. You might need another imaging to help you, but don't necessarily jump into that first. Get the best out of the image you have in front of you. Any questions? Dr. Khan is I'd like to say a word, and sorry about the technical issues at the beginning and the voice too. Just had a whole long day, but yeah, thank you. And hopefully next week we'll do some cases of acute. I might bring some more of the X-rays also, just in the meeting, show more examples. Excellent, thank you.
Thank you, sir.
Thank you very much, Khalil. Absolutely fantastic cases. So I think it was a treat. Extremely high quality cases of GI and the bariums also. So, and I'm sure that many of the present generation of trainees haven't got the sort of exposure to bariums. So now they will be more confident. So thank you very much. And next week, what is the plan for from your side? What are you teaching?
There was some left of X-rays, but I will talk more about acute GI. So wonderful, beautiful cases of acute GI. And probably that time will be more simulation of the Viva. So it will be 2-3 cases. Every candidate have to go through 15-20 minutes. I think that will be the better way. So more of the mock of the Viva, but focusing on acute GI mainly.
Excellent, excellent. And acute GI, of course, is the most important thing for the FRCR exam also. So,
yes, for the 2B. And the challenge always how to scroll them quite quickly and efficiently. So it doesn't take much time. So you have to have a systematic approach and within a limited time of the exam too, which is always hard to scroll the whole abdomen in 2-3 minutes. It's always a challenge. So,
yeah. So we look forward to, and the next session, all of you, the audience, you know what the session is. So see you on the next Thursday. And the co-host, you can please share the feedback slide. And Khalil, thank you very much. That is about it. If you want to say anything, or then we can say goodbye, but we will keep displaying the feedback form for the next 4 or 5 minutes. Yes.
Thank you. Sorry about the technical issues at the beginning, and probably I was